Good morning and welcome. It is my pleasure to introduce Dr. Nikki Bosanoff. She is a physician in the concurrent outpatient medical and psychosocial addiction support service at the Center for Addiction and Mental Health. She is also an assistant professor and head of the Division of Mental Health and Addictions at the Department of Family and Community Medicine at University of Toronto. And she is currently the program director for the Enhanced Skills in Addiction Medicine Fellowship at U of T and a clinician scientist at CAMH. Her clinical work is in the management of substance use disorders and concurrent mental illness, and her research program seeks to answer clinical questions in the management of opioid use disorder. So thank you very much, and I'm really looking forward to this discussion. Over to you, Nikki.
Amazing. Okay, so I have the distinct pleasure of moderating today's panel. Before I start, I want to gratefully acknowledge that I'm calling from the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. And I'm grateful to be able to moderate from these lands today. I invite everyone who's in this room to put in the chat where you're calling from and who you are so that we can get to know you as we have this conversation. I'm going to introduce all of our panelists, and we're going to start today with Charlotte Monroe and Jennifer Wyman. So Charlotte Monroe resides in Stratford, Ontario, Canada. She's a former graduate of the Child and Youth Worker program at Fanshawe College and is currently enrolled in the Indigenous Social Work program at Laurentian University. As a person with lived experience, Charlotte has presented at conferences, co-authored opiate-related research publications, and advised on drug policy. She's a single mother by choice, a support worker, and a volunteer. As a social justice advocate in her community, she promotes peer support, harm reduction, and trauma-informed approaches, and works to address social inequalities in marginalized populations. Dr. Jennifer Wyman is the medical director of the Substance Use Service at Women's College Hospital, a medical educator with Medify, and an assistant professor in the Department of Family and Community Medicine at the University of Toronto. Her academic and research interests are in improving care for people who use substances through education, evaluation, and advocacy across the healthcare disciplines and sectors. Then we'll have two other speakers later in the program. First will be Dr. Melanie Willows, who's the clinical director of the Substance Use Service and Concurrent Disorders Program at the Royal Ottawa Mental Health Centre, an assistant professor in the Department of Family Medicine at the University of Ottawa, and a clinical investigator with the Institute of Mental Health Research. And an addiction medicine physician, Dr. Willows is committed to collaborating with clinicians and researchers to develop new services and improve access and address gaps in care for substance use and mental health problems. Dr. Willows has been instrumental in the development and evaluation of rapid access addiction medicine clinics at the Royal and has developed the digital front door. And finally, Dr. Beth Spruill is a pharmacist and clinician scientist at the Center for Addiction and Mental Health, CAMH in Toronto, and the Leslie Dan Faculty of Pharmacy, University of Toronto, where she's an associate professor and has a cross appointment in the Department of Psychiatry. She received her Doctor of Pharmacy from Wayne State University, Detroit, and her pharmacy degree from the University of Toronto. Dr. Spruill completed a clinical residency and a postdoctoral research fellowship at the Addiction Research Foundation in Toronto, which is now part of CAMH. Her clinical research program focuses on substance use disorders, mental health, medications, and pharmacy practice. So thank you so much. And I'm now going to turn it over to Dr. Wyman and Charlotte.
Thank you so much. I hope everyone can hear me. Nikki, please interrupt if there's an issue with me or the slides, because I won't be watching the chat. So I'm so thankful for the opportunity to present this work. We'll be talking about evidence around carries and our new framework for take-home dosing. Charlotte and I have no commercial support to disclose. In terms of other disclosures, I receive salary support as a medical educator with Medify. And it's the Medify, under the auspices of Medify, that these new guidelines have been developed. And Charlotte has received honoraria for working on this project as well from Medify. And I've received some additional honoraria and have some research work with CIHR and the OCFP. And in terms of mitigating potential biases, although we're both involved in the development of this guideline, The work was extensively reviewed by experts, not only within the group, but by experts in addiction medicine and individuals with lived and living experience of OAT outside of this guideline work. So we'll be talking about the rationale and the process for developing a new framework for methadone carries. I just want to say at the outset that this is focused on methadone and not buprenorphine or SRAM. So we'll ask you to hold that in mind. We'll be talking about recent evidence regarding outcomes associated with increased dispensing of carries during the COVID-19 pandemic. That's a big typo there. And then exploring the framework for discussion and decision-making regarding take-home doses. And I just want to say, well, I'll let Charlotte take it away. But just from my perspective, what a privilege it has been to work with Charlotte and with the rest of the guideline group, and that we are here representing the work of the group together, and feel that sense of responsibility to present well the efforts that went into this project. Charlotte.
Hi, everyone. So basically, the background to this framework was that it's more important than ever to reduce the barriers to OAT as a strategy to reduce overdose deaths, whether people are choosing to use OAT as harm reduction or with the goal of abstinence. Evidence from practice during the pandemic has demonstrated that long-held approaches to methadone carries could be modified to support access to care without increasing the harms. Yeah, that's it for that slide. So in our group, we had 2 physicians with expertise prescribing OAT, 1 pharmacist with focus on substance use, and 3 people with lived or living experience on being on methadone. We recognize the value of the different types of experience and education that the members of this group bring. Our advisors with lived experience are partners in co-creating this guideline document. In order to work collaboratively and equitably, we ask that everyone was committed to the following. Assume that everyone in the group is acting in good faith, willing to listen, willing to incorporate new evidence into our worldviews, not pulling rank, and asking questions to seek clarification and make sure that information and expectations are clearly understood. I'll just note that not every recommendation could be made in the final document. In the case of diverging opinions, the final product will reflect the differences of opinion.
So we put quite a bit of effort into thinking about how we were going to work together, and then committed to doing this deep sort of literature review, looking at many different resources around methadone and OAT, take-home doses, contingency management, diversion, etc. And we really valued the experiences and perspectives of the authors and the experiences of people with lived experience around each of these sub-themes, and went through a very drawn-out process of discussion and refinement to come up with these consensus-based principles and criteria. So they are not GRADE, G-R-A-D-E recommendations for a number of reasons that we can talk about later, but they are consensus-based and based on our review, as we said, of the literature and people's experiences. So I would ask you to hold some, person in mind, and this construct I think could be, an amalgamation of many people that we've seen, those of us who are clinicians, a 28-year-old male who has recently restarted methadone. His dose is up to about 70 milligrams, and it's still a bit low for him. So his use of fentanyl and hydromorphone accessed through the streets has decreased, but not stopped yet. He's still missing a couple of doses a week because it's difficult to get to the pharmacy every day. He's dependent on others for rides to and from work and to the pharmacy. He has been attending his appointments once a week, not twice a week, so that's potentially slowed down his ability to increase his dose effectively. But that's just what he's been able to do in terms of his work situation. Has not had any recent overdoses. Isn't using alcohol, coke, or benzos, or crystal. And the urine sample that he's left most recently is positive for methadone metabolites, fentanyl, opioids such as morphine and benzos, and is not demonstrating cocaine or oxycodone. So, think as we go through this about, how you would be considering carries for Tyler. When might he be eligible? What criteria are you using currently to decide whether or not or when to start carries? Are there other things that could be done to help assist him in achieving an effective dose and to try to help make sure that he remains on OAT to meet his goals? And what are his goals? Have those been explored? Are they reducing risk, reducing use, aiming for abstinence? So many of us prescribers sort of came of age and practiced with the CPSO 2011 guidelines, or for some of us, even before the 2011 guidelines. And those guidelines focused on take-home doses with respect to risks and contingency management. And the risks considered the risks both to the individual receiving methadone and to the community. And we're going to come back to that in a moment because those are significant. And the other, there was sort of a dual balance in those MMT guidelines where contingency management was a second emphasis. And we'll talk about that in a moment as well too. But the idea was that using carries as incentives or rewards for abstinence was an important part of the whole carry program. And briefly, again, those criteria emphasize that an individual should be on methadone for a minimum of 8 weeks before starting any take-home doses. Although, to be fair, there was some room for an accelerated schedule for people with particular issues. And there was an option for Sunday carries when there were no other options available. And the CPSO guidelines focused on this idea of clinical stability, so stable doses, no recent problematic substance use, compliance with treatment directives, stable housing, and then emotional stability and good insight. And I would say, looking back at these, that there actually may have been more room for flexibility than some prescribers felt. But I think the combination of the rigidity of the guidelines, the requirements for urine drug testing, the focus on abstinence, and then the elements of regular assessments by methadone assessors contributed to an environment or a culture in which fluctuation from these guidelines was pretty infrequent and a little bit fraught with the fear that you needed to document every particular sort of exception from the rule for fear of being censured for that. So in terms of the risks of methadone and the risks of carries, these are obviously real. Methadone has a different level of risk than other prescription opioids because of its unique pharmacologic characteristics. And we know that among people prescribed methadone, there are deaths within the first 4 weeks. They're highest within the first 2 weeks and then decreasing after that. We know that methadone is found in opioid overdose-related deaths. Unprescribed methadone is found. Having said that, we know that the greatest opioid of concern in terms of opioid overdose-related deaths is fentanyl. There's no question about it. But we know that methadone makes its way beyond the people to whom it's prescribed, and that people who are actively using unregulated substances are more likely to misuse their own medication or to divert their medication based on a fair amount of literature around diversion overall. So the risks of methadone are not inconsequential. At the same time, the evidence for witness dosing is not super strong. So there was a large study that came out of Scotland and England in 2010 after there were increased overdose doses in association with a rapid expansion of the methadone program. And when they moved back to daily witness doses, there were substantial decreases in methadone-related deaths. But a more recent Cochrane review looking at take-home dosing actually found that they couldn't identify a significant difference in adverse events or mortality in witness dosing versus take-home dosing products, with acknowledgement that the overall evidence is not very strong. So what about the other side of the CPSO, the pre-existing CPSO guidelines around contingency management? Contingency management is a form of behavioral therapy in which individuals are rewarded or reinforced for a desired behavior. It's used in many different kinds of programs. In the world of substance use, there's actually quite good evidence that vouchers or monetary rewards are associated with increased rates of retention and treatment and rates of abstinence. But again, that's the use of some kind of prize, money, gift card, or other voucher. The literature around using carries, so take-home doses of the medication that someone is on, to incentivize abstinence or as a reward for abstinence is much less strong. So looking back at the literature, some of which was quoted in the earlier guidelines, and then looking at more recent evidence, a lot of those studies go back to the early 90s. They're often based on small cohorts and pretty short-term follow-up. So there's inconsistent and not very strong evidence that using take-home doses is associated with higher rates of abstinence. There's somewhat better evidence that using take-home doses is associated with improved retention and treatment. I'll just say again that this raises the question of whether abstinence is actually the individual's goal or the prescriber's goal. And what those guidelines didn't consider, but what we see in the literature, is the additional benefits from take-home doses that people on methadone experience. So by not needing to go to a pharmacy on a daily basis, they're able to spend time in lots of other activities, improve times with family and social activities, better balance, and actually better relationships with their providers. Charlotte, I think this is the opportunity for you to maybe speak a little bit about your thoughts and experience with access to take-home dosing and prescribers' approaches.
Sure. So the quote on your screen there is represents experience from one of our group members in respect to access to carries, and I will speak a little bit about my own experience. When I was on methadone, I never received a carry once in, I think it was like 8 or 9 months that I was on the program. I wasn't at a high dose. I was continuously coming down on my dose, but I was not eligible for carries based on the criteria that my doctor was following. So I lived in a really small town, and our pharmacy was closed on Sundays. So I had to take a cab to the nearest pharmacy that was dispensing methadone on a Sunday, which was an hour away. So it was covered by ODSP. However, that's like 2.5 hours of my time on a weekend, interrupting, whatever plans I might have had to like do whatever. So I often skipped it. I skipped it pretty much all the time. Now then, if you had a holiday attached to that, then I'm missing 2 doses. So that was, problematic in how I felt like physically. So that was a barrier for me for sure. I don't see any reason why I wasn't able to just get those carries for the Sunday and the holiday. I wasn't engaging in high risk drug activity. I was, starting to improve my life in other aspects, volunteering, doing program, CBT. I was making plans to get back to work and everything. So it was a huge barrier, and I feel like having some carries, even though I would have been able to manage all of them myself, some would have just given me that autonomy and like made the relationship between my prescriber better, because it felt like really shaming and whatnot for me to go in there and just kind of like have a urine test and be denied all the time, yet I'm a functioning person. So that's my experience with it, and I'm really glad to see that be a part of this, and that this is maybe the new direction for prescribing carries.
I really thank you for your sharing of that experience and being able to bring your experience and your wisdom to this group. So the pandemic created a sort of natural experiment that has allowed us to look at what happens when people received increased carries. This guidance was released very early in the pandemic, March 20th or 21st, 2020. And essentially it kind of flipped from really restricting access to carries to basically saying, let's give people carries who weren't receiving them previously as long as they can store them safely and are not using in really high-risk ways or acutely unstable in terms of mental health conditions in order to maintain access to care through the pandemic. And there are a couple of studies from Ontario that have evaluated the outcomes of these COVID-19 OAT guidance documents. So the first is a survey of patients and providers that was carried out online during the summer of 2020. Kim Carrace was the lead author on this. And it found that most clients and prescribers felt that the changes to care were positive. Clients felt that the benefits included saving time and money, improved the physician-patient relationship. Some clients reported challenges managing their extra doses, and we can talk about that. By self-report, have receiving extra carries, whether they went from none to 3 or from previously receiving carries up to more, were not associated with increased rates of overdose, emergency department visits, or hospitalizations. And this is a summary of an article, I think the reference is in the chat, that was led by Tara Gomes at ODPRN, and Charlotte and I were both on this article as well. And this used ICES data to look at people who had been on methadone and buprenorphine prior to the pandemic. And it compared people receiving daily doses, maintained on daily doses with those who received additional take-home doses, people previously receiving carries up to 6 to those who received increased carries up to 13 or more, and found that actually increased carries for people who had been receiving daily dispensed methadone prior was associated with lower risks of opioid-related overdoses, lower risks of treatment discontinuation, and of treatment interruption. And this is a little bit of a sort of deeper dive into some of the specific numbers there, both for individuals who were previously receiving daily dispensed methadone and those receiving carries. So to me, I think, it's significant that increases in carries were associated with what I would consider to be improved outcomes, but also the fact that clinicians were, I think, utilizing both the guidance and their judgment to make decisions about who would be able to manage those carries safely. And the study also went back and looked at the ICES rates for ED visits, for acute mental health, or other substance use issues. So to me, I think it really brings forward the idea that in addition to having guidance, we're using our own knowledge of the person and clinical judgment to be able to make determinations. And this is just a brief highlight of some of the studies from the US, where programs also had substantially increased rates of take-home doses associated with positive outcomes. And for context, because this is not yet fully clear, this represents 2 large studies looking at CDC data in the States that actually found that even though within programs, outcomes for people receiving methadone appeared to be positive, across the US, there actually were increases in monthly methadone-involved deaths, starting in April 2020, at the same time as SAMHSA released its guidance around take-home doses. Now, we don't know why this is. It coincides with the guidance around more flexible take-home dosing, but it also coincides with everything else going on in the pandemic, increased access to opioid treatment programs for lots of individuals. So it may have been changes in terms of how those programs were being run, expansion of telemedicine. I know Melanie will be talking about that, but there may be some questions around how people were being assessed. And SAMHSA didn't issue very specific guidance on how to make decisions about take-home guidance. Lastly, when there is an overdose, it's quite possible that methadone is misidentified or preferentially identified as the opioid of choice. So this highlights the fact that we need to continue to balance the risks and benefits of carries for both the individual and the community when we look at changing practices going forward. So all of this is background to the framework that we present to you now, which looks at the potential risks and benefits of carries around reducing barriers to treatment retention, and focuses on an assessment of the individual's overall stability, their ability to store carries safely and to take them as prescribed, and focuses on carries as ranges rather than a sort of continuum from 1 to 6. And the idea of carry ranges again, sort of building from the Ontario COVID-19 OAT guidance, is that 3 carries can be dispensed in a non-consecutive way. So where someone comes to the pharmacy on one day, has their observed dose, and takes take-home doses for the next day, and that there's much lower risk associated with receiving only 1 carry at a time, that this range of carries can be used to assist people with building their stability rather than reserving all carries for people who have already established their stability, and that this category could be appropriate for people who are still using substances as long as they're not using in ways that are high risk. And we'll talk about that in a moment too. 4 to 6 carries per week is more in keeping with previous guidelines where people are expected to be quite clinically and socially stable. And more than 6 carries, and we include that as a category as opposed to previous limits, which tended to focus on a maximum of 6 carries at a time, but would still be quite restrictive for people who've been on methadone and stable for many months and years. So more than 6 carries would be reserved for people with quite long-standing and consistent stability overall. So again, the intent of this framework is really to try to provide a balance between the need for a structured approach where people can understand, both providers and people on methadone, what the expectations are, with the opportunity for flexibility to adapt to the guidance to individual circumstances. And it really recognizes that it's not just that carries are a dynamic process, each individual is on their own dynamic journey, in which their goals, their substance use, and their life circumstances may change over time, and access to carries may help them or be different and may need to be increased or reassessed along the way. And then lastly, as we've said, and I think you heard from Charlotte, people who have had experiences with previous guidelines have felt that rigid or arbitrary systems have negative impacts on their engagement in care and on their outcomes overall. And so we felt that it was really important to try to create, again, this structure that people could adapt, but refer back to again as the basis for this decision making. So Charlotte's going to start by talking about the criteria that we came to as a group after much discussion.
So the criteria identified are a way to operationalize assessment of risk and stability in a way that people, between clinicians and people on methadone. So for example, frequent missed doses can result in withdrawal and increase the likelihood that someone would use their carries early. They could also reduce tolerance. It typically happens when someone is less overall stable. So in terms of stability, typical definitions in the literature, like stable housing and employment disadvantages, people who use drugs because of the intersections between substance use, criminalization, social determinants of health, and substance use. A more practical assessment of stability would be multidimensional, include housing, relationships, their support networks within their family or their community, stuff like that. So
yeah, I think that's a great synopsis. I think I didn't advance quickly enough, but in terms of the criteria, so safe storage should be a requirement for anybody taking home any number of take-home doses. They should be able to keep their methadone out of sight and out of reach of others. And we know that methadone poses additional risks to children. So much back and forth, but we actually felt as a group that safe storage would also include the ability to put methadone in some kind of locking device somewhere. As Charlotte mentioned, amount of time on methadone, so not the first 4 weeks, which is still quite a high risk time for people, even if they're taking their methadone as prescribed. But after 4 weeks, people could begin to receive up to 3 non-consecutive carries, 4 to 6 carries after 12 weeks, and then more than 6 carries would be considered for someone who'd been on methadone for a year or more, who'd already been managing their weekly carries well. Stability, as Charlotte said, is really a challenge because of the expectation that people are stable to receive carries, but the challenges in building stability. The only thing I would add to what Charlotte said is that we included mental health within this category of stability, which is both clinical and psychosocial. So someone could have a mental health diagnosis and be stable the majority of the time, but have episodes where they're acutely suicidal or acutely psychotic, conditions that could affect their ability to manage their carry safely themselves or exercise good judgment, again, putting others at risk if something were to happen to their carries. And so again, this is, the idea being that there is a regular reassessment of how someone is doing, and that if someone is briefly destabilized because of any other reasons, that again, as they are restabilized, the factors are considered with respect to how quickly carries could be reinstated overall. So someone who's establishing stability could still receive up to 3 non-consecutive carries, but people receiving 4 to 6 or more carries would be expected to be quite stable overall. And we may or may not come back to talking about stability. I think missed doses is pretty self-explanatory. If people are missing multiple doses, they're more at risk of withdrawal, potentially of overusing carries as well. So essentially, receiving a majority of observed doses, or 5 of 7, would be a criterion for starting to receive carries. But there might actually be times where a clinician could decide that advancing some carries earlier would help someone to reduce the frequency of missed doses, again, with a goal towards remaining in treatment and stabilizing overall. And then something that we spent a lot of time talking about was substance use. And Charlotte, I don't know if you wanted to speak about that or if you wanted me to.
Sure. So basically, the decision to avoid more explicit conditions is intentional. So when access to carries is associated with specific criteria, such as the number of times per week someone is using, or whether they use cocaine but not opioids, people may be more likely to tell their providers what they need to in order to gain the carries. So they're not being completely honest, and that's a barrier in, that care between your physician or the prescribing doctor and yourself. So I had experience with that personally. So I just felt like I wasn't going to obtain any carries. So I didn't really get a chance to talk about my substance use patterns with my prescriber. It was just pretty much the red X on my chart every week, and that was it. So it wasn't it was a pretty demeaning experience personally. I felt that my goal was to get off my opioid use, and methadone was acting as that helped me reach my goal, and I did that. However, I was not seen as successful based on my other substance use patterns in the eyes of the prescriber. So really, I didn't have specific goals, but even if I had maybe a more open and comfortable relationship with my prescriber, we could have maybe addressed that and maybe figured out something that could be a harm reduction or goal or whatever for the other substance use. So yeah, it could have been a better experience pretty much.
Yeah. Thank you for sharing that. I mean, I can think of many people who were very stable with respect to opioid use and methadone, in my practice in the past, but whose urine samples, when that was what we were relying on, would be consistently positive for coke, for example, who just were never eligible for carries under previous prescribing patterns. And so, again, the issue I think that we decided as a group is that we really needed to think about whether that substance use was impacting the individual's acute safety, their health, their ability to exercise judgment to manage carries safely. And issues such as blackouts, memory loss, and overdoses are obvious risks, but not all substance use has equal risks. Even though in the literature, injection drug use is associated with lower rates of stability and higher rates of risk taking, there are certainly individuals who inject without harms, and there are certainly people who are smoking but not injecting in very harmful ways. And so it's expected that people who are receiving 4 to 6 carries or more would be using infrequently and in lower risk ways. People receiving more than 6 carries expected to be mostly abstinent, but people who are using substances, as long as they're in lower risk ways, could be eligible for up to 3 non-consecutive carries, again, assuming other criteria around stability and storage could be met.
I just want to point out, though, with that too, that for someone using once a week, it's likely that it's going to show up on their urine tests. So, it's not that I was an everyday alternative substance user. So just minor sort of engagement with other substances would still deem me not eligible for carries. And like that wasn't a conversation that my doctor and I had. And I didn't really feel comfortable to kind of plead my case because I already felt judged and like that I wasn't worthy of, obtaining these carries.
Yeah, and you were probably right. Your prescriber would probably have said, well, if you want carries, stop using whatever it is, and then it won't be in your urine, and then it won't be a problem, right? So this is obviously about not just having criteria and how they're applied, but about a bigger change in an attitude also around conversations around people's goals and their use and how information shared is going to be used for or against them, which I think is part of what you're talking about as well. So in this context, urine drug test results are really intended to be used to help understand or see that there is alignment between what someone is telling us, the provider or the prescriber, about their substance use and what's in the urine. That is helpful in terms of building trust and knowing that there is open communication. The urine should show that someone is taking their prescribed methadone. It's pretty concerning if they're not. And if there is an absence of methadone or there's evidence of tampering, then that's an evidence that someone could be exercising poor judgment and not be safe to manage carries. But otherwise, if the urine is showing what the individual has told us that they're using, then that's appropriate. If the urine is showing things that are surprising, then that's obviously indication for a discussion anyway, right? And that's, I think, how urine tests should be used in general. So we would hope that prescribers would think about other considerations, distance to the pharmacy, how someone needs to get to the pharmacy, what their responsibility or involvement is in terms of family, caregiving, work or school, unexpected situations like family emergencies and travel. We specifically identified that transferring providers should not routinely require someone to restart their carries from zero. That's an inordinate burden. Of course, changes in stability need to be assessed. And something we may have time to talk about later is how to manage carries and doses for people being released from incarceration, given how high risk a time that is for return to substance use and overdose, but the challenges of getting to clinics and pharmacies regularly. So key differences, as we said, talking about the individualized approach, starting carries after 4 weeks of treatment, increasing carries up to 6 at 2 to 4 week intervals rather than requiring 4-week intervals, and then moving up and down either within a range or between ranges, depending on someone's stability, rather than sort of the, give 1, take 2, give 2, take 1, sort of game in a way that it felt like things may have been in the past. And that the judgment and the relationship really helps to inform how quickly carries can be increased or resumed. So this little cheat sheet, which is impossible to read, is summarized in the document, which is linked in the chat. Again, the intent is that this is the sort of summary that provides the basis for these discussions, not a tick-off box to be used or implemented mechanistically. And I hope that we have a chance to think about talk about your thoughts around this framework. Does it strike the right balance between structure and flexibility? Are there considerations that you're applying that we've missed? How do you weigh the risks and benefits in your own practice? Are there community factors that you consider? Have you already adapted some of these practices? And how do you see opportunities for spread and reducing inequities to changes in practice over time across our province? So thank you for that. Charlotte, I don't know if you want to add anything in summary. I want to thank you so much for the work that you've done, both in the group as a co-creator and then in this presentation and bringing forward your experience. And I hope we'll have a chance to discuss after the other presentations.
Amazing. Thank you so much for that presentation. And we did put a link to the documents. There's multiple documents on the Medify website. If you have any questions for Charlotte and Dr. Wyman, please put them in the chat. And we'll also endeavor to get a conversation going after we are done with our other presenters. In the meantime, I would like to call on Dr. Melanie Willows to tell us about the virtual RAM clinic that she's been part of, and continue our conversation about increased flexibility that have come out of the COVID pandemic. So take it away, Melanie.
Okay, thank you very much. Very nice to be here today, and going to talk about an innovation that truly came out of the COVID pandemic. And as I reflect on it, absolutely, this never would have happened without the challenges that COVID brought to delivering care. I just want to acknowledge, although I'm presenting this work, I want to acknowledge some of our team members here at the Royal, Dr. Kim Grace, Melissa Webb, Leanne Paisley, all the frontline clinicians in the RAM clinic that helped to co-design this, all the clients and families that helped to co-design this. And there's also several other partner organizations that I'll show you later across Ontario that have helped us to continue to improve this innovation. So, oops. So I do not have any disclosures of commercial support, and I don't personally have any disclosures or relationships with commercial interest. So just briefly, what we're going to talk about today, I'm going to describe how we developed and implemented a digital front door to rapid access addiction medicine clinics. Recognize the importance of co-design with persons with lived experience, clinicians, administrators, technology experts, and researchers, and to understand the benefit of virtual RAM services, both during and hopefully we're post-COVID at this point, or somewhat post-COVID. Just a little bit of background. I think everybody's aware that opioid-related harms continue to rise in Canada. And in fact, that's what this whole conference is bringing people together to discuss this important issue. And we certainly saw alarming increases with the onset of the COVID pandemic. People who have opioid use disorders can sometimes be repeatedly presenting to the emergency department. Sometimes it's difficult for them to receive care. And back in 2015, rapid access addiction medicine, or RAM clinics, were implemented in Ontario. And I think we're up to about 60 or 70 clinics across the province. And I know that there's RAM clinics or similar clinics in some of the other provinces. And for those of you who aren't aware of what RAM clinics are low barrier walk-in clinics that offer rapid access, often same day, to evidence-based care for individuals with problematic substance use and facilitate connections to other services. Just to give you some idea of what that might look like, and I'm just using the example of the clinic that we have here at the Royal. Along with the rapid access, there's a lot of partnerships. So often partnerships with emergency departments, where RAM clinics often get referrals from emergency rooms, connections with primary care flowing in both directions, where individuals may be referred from primary care, or we work with primary care to continue the care post-RAM care, partnerships with public health in accessing naloxone and safe supplies for substance use, often partnerships with withdrawal management, partnerships with community services and community residential treatment, and in our case also a partnership with a system navigator or Access MHA that can help the individual access all the different other services that exist in the system. So here at the Royal, Dr. Kim Grace has been the prime investigator on several CIHR grants looking at the benefits of RAM clinics. And some of those have been published, and some of those are just being submitted for publication. And what those studies have shown is that RAM clinics increase access to care. They decrease alcohol and opioid emergency department visits. They decrease opioid hospitalizations and deaths. There's high client satisfaction. And in fact, individuals that are served in RAM, overall to the whole system, there's a savings of close to $1,400. So why I'm sharing that with you is we had a model of care that was easy to access, that we knew worked, that we knew improved health outcomes. And then COVID came along. And although this may not have been the case in everybody's setting, we work within a mental health hospital. All of a sudden, we were told you can't have people walk in. And so this greatly interrupted access to care. We could quickly change to phone calls, video. We used OTN, we used Zoom, we used DoxyMe. But despite all of this, we really felt that access to care had greatly decreased. And having to set up appointments, having to play phone tag, having to create Zoom links and send Zoom links. And the other thing that it really affected was the ability to provide interdisciplinary care. In most RAM clinics, there's multiple different types of disciplines in that clinic. You know, maybe a social worker, maybe a nurse, maybe an addiction counselor, maybe a peer worker. And often when people would come to the clinic, they would see more than one person. And so as soon as you start having to make phone calls, you have to send Zoom links, it becomes very difficult for that individual to receive care seamlessly from multiple different individuals. So from that, you know, myself and some people, some other individuals with me, we started to investigate, you know, is there a product out there that we could use? We need something where people can walk in virtually and, you know, go to a waiting room, and then they can see multiple people and have the same experience that they would have if they were walking into a RAM clinic. And so from there, that's how the digital front door was created. And it truly was co-designed with patients and their families, the clinicians that worked in the RAM clinic, our administrators. We had a technology expert within the Royal, along with actually a technology company that would meet directly with us to figure out what this needed to look like. We also evaluate everything in our RAM clinic, so we also had all of our researchers involved to make sure that every different component was looked at and considered. And so what we were able to create was a virtual walk-in clinic that individuals could easily access from a smartphone, desktop, laptop, or tablet. We were able to integrate screening, intake, and evaluation. We were able to create that team-based care where it was easy for the individual to see multiple individuals in one appointment. And we also created a dashboard that clinics could use to keep track of all the individuals that they needed to see, whether it was by video, phone, or in person. And this resulted in us being able to serve many more individuals than we used to serve because of the technology. So with something like this, with the co-creation is ongoing, and we went through several different initiatives of this, or iterations, to get to where we are right now. When we first stood up the technology, we were using a Zoom integration, and it had many issues, and the patients had a lot of difficulties with it, which led us to using different type of technology. And as we went along, the technology became better and more friendly to the individual that was using the technology. From there, we presented some of this at various different conferences and to different individuals. And we had many groups across Ontario reach out to us and say, hey, can I use that technology? And you'll see here, Jen Wyman's part of this panel. She's part of Women's College, and Nikki's part of CAMH, two of the partners, but also Lakebridge Health, Addiction Services Central Ontario, St. Joseph's Care Group, Stonehenge, the Brent Haldeman Norfolk RAM Clinic, and Health Sciences North. And so we had partners from all different areas of Ontario that now are using this digital front door and are part of that co-design really of improving what it looks like and how it functions. And so I'll just quickly share with you how it works. Basically, it's web-based, so you do not need to download any app or anything like that. As I said before, you can use it on a smartphone, desktop, laptop, or tablet. Many of the clinics also have a nice URL code that you can just take a picture of, and it takes you right to the site. The individual answers a few basic demographic questions about themselves and some basic questions about what kind of help they're seeking. And then basically they're told that they're in the queue to see an individual, and there's a button that they press as soon as somebody's available to see them. In our clinic, we're able to actually track how long it takes for people to be seen, how long they see individuals, how many individuals they see. And so our initial data showed that it was about 3 minutes before that person was triaged to a clinician, and about 9 minutes before they were seen. And then that individual basically can see that one team member, and if they need to see another team member or multiple team members, they basically do not need to do anything. They just stay in front of their device, and that next individual will join, and they can have that visit very easily. And I apologize with virtually, I would do a demo, but it gets a little challenging with the different technologies when you're in a virtual conference. From the clinic side, what the clinic sees is a list of those individuals that are waiting to be seen. And that can be a list not just of the people who've joined through the through the digital front door, but you actually also can add, if there's individuals that you need to make a phone call to, or individuals that are coming physically into the clinic, you can also add them to this dashboard that quickly can tell you, who's waiting to be seen, who are they supposed to see, is somebody high priority, which for different clinics that might be different things. That might be pregnancy, and helps to kind of function with how the clinic operates. As we brought the partners together, this has allowed us to really have different approaches to how do we use this technology. The RAM clinics already existed, so that's nothing new, but how do we use this technology not to replace in-person visits, but to augment in-person visits and to augment access. And some of the things that we've done at the Royal Clinic, and some of the things that some of our partners have done are things like outreach. So for example, an individual might be at a shelter with their worker. They might not be so interested in coming to the RAM clinic, or they might be concerned about coming to the RAM clinic, and the caseworker that's working with them could help them log on and have an initial visit with somebody from the clinic. We also sometimes have individuals after they've been discharged from the emergency department, the social worker, they're working with them to log on to make that initial contact. We've had people join from the primary care office. We can provide services to some of the bed-based services or residential treatments that might exist. And basically wherever that person is living, potentially they could connect. And again, making, I think, all of the different partners who've been involved across Ontario are, as we go along, figuring out how can we continue to improve access, and if there's issues with internet or with other things coming up with partnerships or other ways that people may access. Just as far as we do collect information from the patients when they are finished their visit from the digital front door, and other Other outcomes, you'll see that 93% of patients were satisfied with their experience. And some of the comments, I like the fact that I can receive the services from home. I was shocked at how quick and easy it was to access this service online, giving me the experience of feeling understood and hopeful. And as far as the staff in the clinics, 100% of them agreed that it's increased their capacity to see patients, and they are able to meet standards of care using the digital front door. People like that it's available when someone's ready to take that courageous step to ask for help. A lot of our clinics have been able to access, improve access for large geographical areas. So for our clinic in Ottawa, we've seen a 20% increase in individuals that we're seeing outside of the Ottawa area. For those of you who aren't familiar with this area, kind of our general catchment area would be about 2 hours in multiple different directions. And so when it was only physical walk-in, it's not very feasible for those individuals to come that long of a distance. And some of our partners are in the north, and they have even larger distances. And so it's greatly improved the access in those areas too. Easy to use, so the clinicians have found it easy to use, so have the patients, and reduces the barriers of stigma. Again, some individuals may not feel comfortable walking into a clinic, but might be willing to see somebody virtually. So in summary, I think first and foremost, this innovation came out of COVID. We never would have created it without COVID. Key to the innovation was the co-design with clients, with the frontline individuals who are going to use the technology, with the technology company that was right in there working with us to understand what those needs were. And through this, we've been able to increase access to evidence-based care, increase equity in mental health and addiction care, and that team-based care, that allowing that to be quick and easy. And I think, overall, the outcomes for patient-clinician experiences have been positive. And as we continue to work to improve this technology, we will continue as our group becomes larger. We have more amazing ideas to make it even better and easier for those that are using it. So thank you, and I look forward to questions later in the panel.
Thank you so much, Melanie. So we are going to break now. If there's any questions that you've had from either the presenters to this point, please put them in the chat. And otherwise, we are going to return at 11:35 for the rest of our panel. Thank you so much. Hi, everyone, and welcome back to our session on innovations related to the COVID-19 pandemic. I now have the pleasure of introducing Beth Sproul, who's a pharmacist and clinician scientist, and she's going to talk about pharmacy innovations resulting from the pandemic. As always, if you have questions, put them in the chat, please. Thank you.
Okay, so thanks for the opportunity to talk about pharmacy practice and some changes during the pandemic. I have, there we go. I have no commercial interest to disclose in this area. And so for the next few minutes, what I want to talk about is just generally kind of set the scene with pharmacy practice, and then move into the scope of practice changes that some of them that have occurred over the course of the pandemic in this area, and some associated research findings in that space, and then just a little bit about future practice. So I wanted to start with just kind of framing pharmacy practice to start with, because I think everybody has kind of their own perspective based on their experiences. And I just wanted to emphasize that pharmacy practice, as with everything, I guess, has been significantly evolving over the years. from just supplying medications, and then, during my father's time in his community pharmacy, more around evolving into providing sort of specific services and medication information about medications from, and less about compounding and making the medications. And then more recently, over the last couple of decades, it's really been moving more towards sort of providing actual patient care. So not just sort of isolated information, but actually as clinicians assessing patients and working with them to optimize their medication therapy, and in specifically things like making sure that it's the right drug, it's most effective, it's safe, etc. And so pharmacists currently have this role in a variety of practice settings. Most people are probably most familiar with the community pharmacy role, where there is a primary role of dispensing medications, but also with that clinical role as well. Also in the primary care setting there are pharmacists embedded in family health teams. And then there's pharmacists working clinically in hospitals, and many of them tend to develop sort of specialties in different areas, or working with long-term care facilities in sort of a specialty setting as well. So all of that just to kind of set the scene, where for this presentation we'll be focusing primarily on community pharmacies and sort of the dispensing aspect and care for patients with respect to OAT. So early in the pandemic, where there were adjustments being made, we developed, the pharmacists at CAMH developed a guidance document that kind of accompanied the broader document that Dr. Wyman spoke about in her talk, in guiding practice during the pandemic and in sort of anticipating changes that would be needed. And so just for example, we just suggested things that sort of made sense at the time around exploring alternatives for witnessing doses, if that was absolutely needed. Consider delivering smaller quantities of methadone in particular if the person was getting a large number of carries, thinking about safe storage. If the pharmacy's services were being restricted due to the pandemic, make sure that they facilitate transfer of care of patients to another pharmacy. And really supporting take-home naloxone kits and harm reduction approaches. So these are all kinds of things that could just be done within the scope of pharmacy practice. But over the pandemic, other levers were undertaken to help for the pharmacy profession to kind of really help more. And in this systematic review, they looked at sort of the legal levers that could be used to have practice extensions, looking at practice in Europe, Canada, and the United States in particular, and more generally around the pandemic, having pharmacists performing screening tests, allowing vaccine administration, compounding to mitigate drug shortages, and just in general, overall, found that these sort of novel legal extensions allowed really helping pharmacists maximize their potential contributions during the pandemic. Now, more specifically in Canada, the legal lever that was used was the CDSA exemption. So the CDSA is the legislation that regulates substances and restricts access to certain substances, but then gives exemptions so that they can be used, for example, for medical purposes. And so in this case, the government created some new exemptions to the CDSA restrictions, and for pharmacists to be able to be exempted and provide an expanded scope with respect to managing controlled substances specifically, so including OAT. So this graphic comes from some information that's posted on the Canadian Pharmacists Association website around these specific exemptions. And it basically that allowed the provincial authorities to then grant these expanded scopes to pharmacists in their provinces, since it's regulated provincially. So these included extending, renewing prescriptions, adapting prescriptions, being able to transfer prescriptions between pharmacies, allowing staff to deliver the prescriptions, and to be able to accept verbal orders. And as I said, this is needed. Each of the provinces needed to kind of enact these, and in Ontario, it was enacted. Each of the pieces, it kind of varied across the country, but specifically in Ontario, I guess the key thing is that one of the provisions that they made is around in changing the prescriptions or adapting the prescriptions. They needed to first try and contact the prescriber before using that authority. So if the prescriber wasn't available, then they were able to renew or adapt the prescriptions. Also, one of the other restrictions is, even though there was a provision around changing the dose, this was in Ontario. This was not allowed to, or not to increase the dose of OAT, for example. So looking at some of the research that's been conducted around what's happened during the pandemic in using these exemptions, this is a study by the folks at ICES and the ODPRN group, where they looked at the narcotic monitoring system prescription database to look at how often pharmacists were actually taking advantage of the exemption to prescribe controlled substances. So this is controlled substances in general. And it's essentially, they found a modest increase in prescription and prescribing by pharmacists. And they concluded that it sort of highlighted the demand for pharmacist intervention and the potential for pharmacists to serve as kind of a last line of defense in ensuring continuity of care. And really that was the focus for many of these exemptions, was around ensuring continuity of care. The Canadian Pharmacists Association also took on seeing how pharmacists were taking the uptake on the exemptions use. And they've posted some results on their website. And so I've just taken some of that information and to share today. So this survey was for almost 1,500 pharmacists participated. It had pharmacists from across the country, with, I'll just note, 40% from Ontario. And these pharmacists represented both rural and more urban areas. So overall, with respect to patients requiring a change or a refill for an opioid or a controlled substance, most pharmacists had done this, endorsed having done this over the course of the pandemic to date, with very few having never done it. More specifically, they also broke down when this was used for opioid use disorder versus for chronic non-cancer pain patients. And about 50% of the pharmacist respondents had extended, renewed, or adapted opioids for opioid use disorder. As you can see on the red graph, whereas there was slightly more, 66% of the pharmacists had done this for chronic pain patients. So more frequently for chronic pain patients, but a significant number for patients with opioid use disorder as well. So this was a pharmacist survey, but they did ask the pharmacists their impression of the impact this had on patients. And mostly it was very positive or somewhat positive. What was posted didn't describe what some of the negative effects might have been that were endorsed by some pharmacists, but overall, the vast majority felt that these exemptions had a positive impact on patients. Now, our group in Ontario had also done a survey of Ontario pharmacists, and specifically asking about uptake of the activities during the pandemic. And we had similar results where, 60% of the respondents had indicated that they had either received or transferred a prescription specifically for OAT to or from another pharmacy. That they had accepted verbal orders for OAT was around 45%. That they authorized delivery of OAT to patients, over 30%. And then also, although not related to the CDSA exemptions, they were a smaller percentage, less than 10%, had part-filled carries when authorized for large amounts, or conducted sort of virtual witnessed dosing. To kind of expand on those more quantitative kind of data around opinions and what was happening, I wanted to share this study done in Canada as well, looking also at the pharmacist's expanded role, specifically providing care for opioid use disorder, but this time it's a qualitative study. And so they interviewed 19 pharmacists from across the country, in working in community or primary health team settings, and who specifically had used the exemptions. And overall, I just wanted to start out with saying that they found that pharmacists were able to provide continuity of care to patients who would otherwise been unable to access that care, and the exemption permitted pharmacists to assess patients and provide the OAT through this expanded role. And I'll just share some of the quotes from this study. Sort of looking at the different types of extensions that were used, for example. So we were able to do the emergency supply for a patient for a week to bridge him to be able to connect with a new doctor to sort of bridge that change in prescriber. They were able to transfer a prescription for someone who was just visiting for a funeral, and so they were able to accommodate that. And then a comment about the verbal order piece is that, they emphasizing the gap in communication between doctor and pharmacist, which can be a challenge sometimes. And so the found that the authority to be able to, when they get in touch with the doctor, to be able to take that verbal order and just act on it right away without waiting for a hard copy prescription to come through, that was much more efficient and beneficial. And then also, just finally, I thought it was interesting that one of the pharmacists talked about the importance of relationships between the pharmacist and the prescribers in this area, and also the prescribers' feedback was generally positive when they were undertaking these things, like letting them know that they prescribed an interim supply for a patient. In addition, over the pandemic, we've received some anecdotal feedback from pharmacists in our interactions. And so just wanted to share some of these as well. So pharmacists felt that absolutely these changes have helped clients, and particularly, for example, when things may arise on Friday evenings or weekends, and so to be able to make extensions to bridge that care. Felt that being able to transfer the prescriptions gives clients the choice and mobility around Ontario. Also, the other piece around verbal orders, being able to take verbal orders, kind of helped during the pandemic because some prescribers were working from home or out of an office in the evenings, for example. Although there were some concerns around kind of the patient record then being spread across different pharmacies, where not all pharmacies are yet using Connecting Ontario or Clinical Connect in the community. And so that's something that is important to address. And I wanted to just follow that up with an example of a particularly innovative practice. And this was highlighted in a Medify newsletter. And so you can see the whole piece on their website. But I thought it was kind of exemplary of some what some pharmacists in Ontario have done, sort of a little bit out of the norm and really using kind of an outreach approach. And there are examples across the country of pharmacists and pharmacies doing this. So this is a pharmacist in Guelph who, through the community pharmacy, has really established kind of an outreach program. And so I encourage you to read the whole piece that's on the website, but I just took out a few of the quotes to kind of highlight what they're doing. So this is a case where, for example, on a typical day, my driver and I see about 60 patients at a variety of locations. Looking into emergency shelters, subsidized housing complex, motels, roadside campsites, admission services. So 60 patients in a day is quite impressive. He describes it that the bulk of his time is spent ensuring that daily medications are not missed, but significantly also has time when clients want to talk. So he listens to the patients, and as needs become apparent, also helps assist with a kind of handover to outreach organizations to further support the people. And also of note, he indicated that recently they started providing long-acting buprenorphine injections in their pharmacy and wants to kind of extend that out into the field as much as possible. So an example of where pharmacy practice could go and how pharmacists can continue to contribute around ensuring access to medications. So there's been, in addition to some of the things that I've described in these slides, there's been a lot of calls for pharmacist support in pharmacy world, in pharmacy publications, and particularly, I would say, in the US as well, where the pharmacies and pharmacists do not have as large a role in supporting OAT therapy and patients as has been the longstanding experience in Canada. And so they are recognizing some of the advantages and specifically the way things are regulated in the US, looking at buprenorphine and sort of leveraging community pharmacists and supporting buprenorphine therapy there. And that's something that the pandemic has definitely kind of raised a lot of questions in that area. So just with respect to kind of seeing where pharmacists are at, perhaps in furthering their scope of practice in this area, perhaps taking on further responsibilities, even past the, in addition, because of the from experiences from the exemptions, but just going forward. And in this, our survey of the community pharmacists in Ontario, we also asked about their willingness to independently undertake sort of further responsibilities in the OAT area. And so some pharmacists, in the 25 to 30% range, would be willing to determine appropriate dosing schedules, reinitiate therapy after missed doses. So independently do that, adjust ongoing dosing based on clinical assessments, designing and managing initiation of therapy, or designing and managing a planned tapering regimen. And so from that, in the question we had said, with appropriate training. And so then I also just included the results of other questions that we asked, where I thought it was interesting that and encouraging that most pharmacists felt comfortable in providing OAT services and found that providing OAT services a valuable and rewarding experience. But at the same time, a large proportion of them, 65%, wanted more training in providing services for substance use disorders in general. So that's certainly a message that we are trying to work with in figuring out how to best support pharmacists in their roles in the community with the changing landscape in OAT management and with the ongoing opioid crisis more generally. So I just wanted to also finally mention that the Canadian Pharmacists Association has had a longstanding priority around promoting pharmacists' role in opioid stewardship activities, as well as in opioid agonist therapy support, and they have a goal to have the CDSA exemptions be further extended and made permanent. So the exemptions were initially for a shorter period of time, and right now they've been extended through till 2026. But we're looking to have those be made permanent. But also CAPHA is sort of taking it a step further and sort of and really advocating for recognizing pharmacists as practitioners under the CDSA, kind of similar to physicians and dentists, for example. So we look forward to that continuing work. And so finally, just the key messages I'd like to have taken away is that we really think that pharmacists did step up to address patients' needs during the pandemic. So on the positive note, we think that the early indications are that the CDSA exemptions have been utilized effectively by pharmacists. Pharmacists are certainly willing to engage in more in supporting patients on opioid agonist therapy. And we definitely recognize that that is important to help encourage more pharmacists to engage in this in more pharmacies. But also recognizing that further educational and system supports need to be developed and evaluated to really improve care, because we've also heard about some of the challenges that people have when attending pharmacy for these services. And most importantly, we've kind of talked about, and mostly this research to date over pharmacy practice over the pandemic has been from the perspective of kind of what pharmacists are doing and what they're thinking. And we really need further research to evaluate actual patient outcomes and experiences, and of course to involve people that experience to plan the best way forward in improving pharmacy services. So thank you. Look forward to the panel discussion.
Thank you so much. So if the other panelists could join us right now, I will invite the audience members to put any questions that they might have into the chat. But in the meantime, I can start us off. So all four of you have described kind of innovations that have come from the COVID pandemic to increase flexibility in the delivery of OAT care and substance use care generally. And then we've also heard a bit about some inequities that may result in with respect to incomplete application, let's say, of these innovations. So for example, pharmacists who may choose, I guess, or elect not to implement these, providers who may or may not offer these or engage with them. So I wonder if you guys could comment on that and how we ensure that these innovations are applied equitably.
I can start. It's such a tricky question, and I think I have more questions than answers to that, Nikki. I think, in the days where the college mandate and assessments and education, like everything was much more kind of streamlined and also sort of felt enforced. There was uniformity of practice, and that was not necessarily helpful for people. But in the current situation, I think what will shape practice is community standards of practice, I hope. And so, events like this and others, developing new educational modules that help to share new guidance, and maybe even ultimately, sort of another national look at what standards to OAT care could look like, recognizing that there are different issues and different considerations in different parts of the province. But I think there are pockets, right, of different types of care environments, from primary care to OAT standalone clinics, some of the large clinic groups which have their own internal practices. And so I'll just say that one of the things that we recognized is, that there are lots of different ways where people get their information. So part of the guideline development for us was to come up with a plain language document and a one-pager, actually, thinking that this is something that could perhaps be posted in pharmacies where people on methadone could receive access to information and then take this to their providers, who could then link to the more full documents, wanting to kind of leverage partners within other communities, including the associations of people who use drugs, to try to make people aware and enable people to advocate for themselves, but recognizing also that that's very challenging for people. So there's a lot of work to be done.
Yes, and I agree with that. I think it is quite challenging, because it is sort of a challenging clinical situation if you think of a pharmacist in a pharmacy, again, on the weekends or Friday nights, and can't get a hold of anybody to kind of help with the decision making, and it is very different than it was before, because it was very clear, you can't, no, this is the rule, I can't do this at the and now it's more of a clinical judgment. Is it too risky to release the dose, depending on what's going on, and really relying on that kind of assessment and the situation, or is it better to give the dose so that, of course, people don't then need to go out and use, or less likely to need to go out and use the contaminated supply. So those challenging situations are quite. It's something that we've been trying to think of how best to support pharmacists now, when the kind of more clinical judgments are needed compared to previously. Also, something that we're hearing quite clearly is around one of the key barriers for people accessing OAT is sort of stigma that they've experienced in coming to pharmacies, and the barriers from the pharmacy practice perspective. And so we are working with PHAC on a campaign, or kind of a sort of messaging to try and help with that, and something that will use sort of different levers in the pharmacy world to try and help mitigate that barrier, so that people can feel supported, and really that pharmacists can embrace the current vision for care, which is meeting people where they're at and being non-judgmental, understanding what support looks like, and not creating barriers.
I just want to jump in too and say that, like, the communication channels between pharmacy prescribers are that is something that could take hours or even days to get a turnaround on. So, if there's a person who is seeking something from the pharmacy for their methadone treatment, they could be waiting there all day and then not get what they need, and then they're out finding another resource. So there's barriers in that sense too.
Yeah, I agree with that. It's certainly in some of the interviews that we've done with prescribers and pharmacists and people that have experienced around OAT and during the pandemic, that communication piece is, and the barriers that cause lost prescriptions that mysteriously, needing the fax system, and the faxes kind of disappear into the ether, and trying to, it just seems that there's unnecessary barriers from a communication point of view, and really communication is what's definitely needed, and setting up a good system for that, where when pharmacies are, have people coming from a variety of docs, and likewise docs have people going to different pharmacies, it's definitely a challenge, but I think it is something that we need to focus on as well.
Oh, Melanie, I think we don't have audio.
Sorry, can you hear me now? Okay. I was just going to comment, as a prescriber, certainly these changes were really welcome, and I hope they continue. I think I would never want someone on OAT to have to go a single day without their OAT because of a mistake I've made, or a mistake where a fax has disappeared. And so it's been so welcome to have these changes, because unlike maybe other medications, going a single day without medication is a really high risk day where something really terrible can happen. So anyways, Beth, I don't know who advocated for all the changes, but it's been very welcome, and certainly, being able to either have the pharmacy make sure the person has it, or being able to receive a phone call and easily be able to prescribe over the phone as I'm driving somewhere an hour out of town and can't get somewhere to write a prescription. I think the changes have been fantastic.
Thanks, everyone. We have another question in the chat. What does everyone think about the best ways to support the development of these clinical judgment skills? So I think when we think about that, we mean, like, how do the clinical judgment skills to assess if it's safe to give carries, the clinical judgment skills to, bridge that dose on the pharmacy end. And then also, I think in virtual care, there's lots of clinical judgments also in terms of whether virtual care is appropriate. So how do we build those skills and maybe set boundaries also while we're doing that? How do we encourage our trainees to have those skills?
I think that's another great and tricky question, because some of it comes from experience, right? Sort of living and working in this space for a while. I know that the simulations side of the course that was designed by CAMH was intended to try to provide an opportunity to work through kind of different cases and talk through in that safe space. And I think that case discussions are a great way to do that. I think what's important to remember is that people are not cases. So one of the great ways to I think advance the discussions and help people support their skills is by having opportunities like this that include clinicians from different types of backgrounds and clinic settings, and also people with lived experience who can help explain what the real world is like for them. There are so many different facets that I think people who are prescribers, and not fair totally to make assumptions or generalize, but I would say most of us don't have lived experience of the kind of substance use that we're treating when it comes to OAT. So I think that to be able to think about the application of criteria and clinical judgment, it's really critical to make sure that we have those voices in our head and that we think about the implications of our decisions.
Yeah, some of the ways that we've been thinking about it from the pharmacy practice perspective is we're actually sort of putting together a small grant to kind of explore what support models we could put in place for pharmacists, including perhaps a focused ECHO style kind of educational initiative where cases could be discussed and kind of and help pharmacists with their skill of the patients. I think other things that could be explored are perhaps explore the experiences in BC where they have kind of a helpline where frontline primary care practitioners can speak with a specialist and get actual clinical guidance on the spot in real time kind of thing to support those. And so looking at the outcomes, the effectiveness, the needs. I'm not sure if work has been done or people have had discussions on that in Ontario yet, but it seems it's something that we've been thinking about from a pharmacy point of view.
Melanie, anything to add there?
I don't think so. I mean, I think multimodal. I think different people learn in different ways, and so I think some of the different things that have been mentioned, I think are helpful. I mean, we probably don't have enough opportunities for clinical placements, but for some people, you know, that may be helpful. And then, you know, building some individuals that maybe can be train the trainer, right? Or where you have people who have a certain level of skill that then can mentor other individuals. But I think it's exciting that we're talking about this, and I think there's momentum to move this forward.
Yeah, I think the one-pager documents in the plain language are important to include, and just getting them out there wherever they might be accessible, and with the prescriber as well.
Okay, thanks everyone. Another question that I wanted to pose to the panel was around, I guess, moving forward, looking forward, how do you see both implementation, or where would you like to see expansion of these innovations? Like what are the next steps to bring these innovations fully into practice, do you think? Or beyond, you know, what's already been described, how else could they be extended?
I can go first for this one. As far as the digital front door, I think, you know, ideally it's implemented in all the different health regions in Ontario, but not all the clinics. And so I think if there's interest and there's funding, then, you know, ideally that would be available in all the clinics, which would then improve access across Ontario. We are already implementing in another province in Canada, and potentially there may be others going forward. Again, it's a technology to enable care. It's not replacing in-person care or that judgment of or you know of only seeing people in person, but anyway, so I think we're on our way. I think the other thing that we're working on as a group that's already established is having kind of a landing page, as opposed to having 9 different landing pages, so that people can be directed and make it even easier for them to find the service that's closest to them. So.
I think it would be helpful to kind of explore what we know about the importance of having that primary care wrapped around the OAT services, and trying to kind of advance that in practice. So certainly community pharmacists could help with that in a variety of ways. But just sort of looking at the system as a whole, because that's a really big missing piece. Is I think, you know, everybody's aware, but it might be time to kind of try and move on that and remove the isolation of OAT as a separate thing.
Yeah, thanks, Beth. I was going to speak to that too. I think part, you know, the theme around this is not just changes prompted by COVID, but I think the underlying theme is more person-centered care, right? What have we learned about how to adapt OAT care, and stop thinking about all of the barriers or putting them up, and thinking about how do we make care more accessible for people who use substances, like we want to make care more accessible. So I know one of your particular passions is thinking about how to integrate care into primary care for people who use substances. So it's both the wraparound, but also you know, trying to break down some of those silos. So that's a really big piece, but I think it's starting with some of the education I mean, I can only speak from the medical perspective. I can't talk about all of the other disciplines, but undergraduate medical education, you know, AFMC modules, postgraduate training, that's really trying to do some work around shifting stigma, building skills so that they don't have to be super specialized, and know that the specialized skills exist for when they're needed, but really building capacity. And having said that, that's a huge ask given what primary care is dealing with overall. But I think that this, you know, opportunity and having these kinds of conversations that bring together people from different approaches. So we've got CHCs, we've got family health teams, we've got individual providers, we've got people working in clinics, and start to think about how we can work together more efficiently to leverage our our expertise and build that capacity. Sorry, and I should have said also from harm reduction, right? And others here, so that it's not also medicalized either. I think that's what's going to make, hopefully, a difference over time.
Charlotte, anything to add there? Otherwise, I could move on. Okay. I will do a last call for questions from the audience because we still have some time. Feel free to put any questions in the chat, and I'm very comfortable with silence, so I could be silent, but I'll also I can continue asking questions also. So again, feel free to put them in the chat. I think, yeah, I think as providers, and many people are in like fee for service work or compensated in different ways. I wonder if anyone can speak about how those models, I guess, for the virtual care and for pharmacy, like how has compensation in the disciplines either enabled or created barriers for this? And I guess it also applies to take-home doses, maybe also in terms of frequency of visits, that kind of thing. Yeah, how should we think about that? Is there points of advocacy to our people who fund these programs that we should be thinking about?
Beth, I'm so curious about the pharmacy side of things. I wonder if you would go first on that, and then I'll chime in.
Yeah, I think, yes, I have to say that it is one of my limitations because I'm not like a pharmacy owner. I'm not as, intimately familiar with what the specific barriers are, etc. But I think in general, it comes down to if for any service, for it to be viable, it has to be supported. And so, things like doing those outreach to people, being able to take the time for those assessments, being able, I think, one of the big problems in pharmacy is being paid through dispensing primarily. There are more and more programs kind of coming on over the last 10, 20 years, like meds checks and other payment models for cognitive services. But to be able to, but to be relying on kind of volume as a lever or key driver in practice is our system. It's our economic system, so you can't really complain too much. But it would be nice to have other models, and I would say kind of leveraging more pharmacists in family health teams that can then work with the dispensing pharmacies, and that type of thing, where it's where there's, the way things are compensated now, more of an opportunity to provide that kind of relationship kind of clinical services for people. Yeah.
Maybe before Melanie speaks about sort of billing codes with digital, because she's, I know, delved into that. I guess you're right, Nikki. Just overall, if we are practicing in a more person-centered way, having people come in less frequently, relying a lot less on urine drug tests or doing urine samples at labs rather than in the clinic, there's a significant decrease in what physicians can bill for that. And there is a huge issue that our billing system is based on urine drug tests. I mean, it's just, there's so many things that are wrong with that. So I do think from an advocacy perspective, there has to be a big revisioning of how to reimburse for care for people who use substances that can include the time that's required around counseling and finding other supports and managing the logistics of prescriptions that's not just based on, the code for an interaction. So it's unfortunate that the urine tests are financially incentivized. It's created a system that's really problematic. There are definitely people who are working, to change that, and also working just in that system, without relying on that. But it will take a long fight, I think, given the systems that we're working in terms of funding overall.
So I'll just speak to the digital technology. Certainly, during COVID, there were digital or codes for virtual care that were available, and then there kind of was a deadline where those codes were going away or being altered. Fortunately, we did work with Ontario Health to become an Ontario Health approved vendor before that happened. So that helped, that there was no gap there. There was also a lot of advocacy done, not necessarily by ourselves, but by different groups in Ontario around not cutting off those virtual care codes for opioid agonist therapy, because there was a lot of fear that people would stop receiving care, and there would be interruptions in care. So I think that also helped things to move forward, that those virtual care codes, or they were, people were still allowed to use those codes specific to addiction medicine.
Okay. Well, I'll just offer now space for anyone to give any last thoughts or summary statements before we move to a break, before our keynote. Take it away.
I just had a quick question, and I apologize if I put Beth on the spot again. Do you know of any work that's being done around pharmacy potentially administering extended release buprenorphine or Sublocade? Just because I could see that just with some of the barriers around having to have it maybe delivered for primary care and so forth, that might be another good partnership that would enable primary care to provide that treatment more easily.
Yes. Thanks for that question, to be able to bring that up. It's definitely a big topic of conversation in the pharmacy world. There are pharmacists in pharmacies doing that now under medical directives. And there is some research work from a policy perspective looking at pharmacists' role in those types of long-acting injection kind of service. It makes sense, I think, from pharmacists have been getting expanded sort of injection kind of scope. Starting with vaccinations and going from there. So I'm from a timeline point of view, I don't know, but it's definitely a topic of conversation, and I think it's and I think it's a kind of a welcome addition that could be very supportive, and also, because the current mechanism for Sublocade, long-acting injection buprenorphine, to be service is kind of bypassing pharmacists, because it goes directly to, the pharmacist doesn't interact with the patient and be able to kind of do that, the usual care and checks and balances and whatnot that they would do. So I think it's from helping to support access to the injections, as well as just from a clinical care point of view, it's definitely something to promote.
Thanks so much.
For the opportunity to be part of this panel is what I would say, to bring us all together, to look at the learning and think about what comes next, and especially for including for Charlotte. And thanks for participating, Charlotte.
Yeah, glad to be here. Thank you.
Thank you so much to everyone.